Yes, sir. So we have alumni from Delhi, Dr. Adil Beg today, one of the leading names in intervention nephrology. So over to you with the students of Delhi
Thank
and apart all India, sir.
thank you, thank you, thank you. Um, Good evening to everybody. I'm Dr. Adil Beg. I'm a full-time intervention nephrologist at Ujala Cygnus Hospital. I do see the nephrology cases. I do OPD of nephrology, but I am focused. My focus is much on the intervention part of the nephrology. So it's my pleasure that once it was my dream that uh, mm, that one day I may be on the opposite side of the table. So thanks for giving me such opportunity, Dr. Kher and other uh, seniors. I thank them through Mr. Puneet. So I may start today. So my topic today is that's a uh, introduction to intervention nephrology. What is the intervention nephrology and why there's a need of intervention nephrology? And as uh, as ultrasound is the basics for the intervention nephrologist, particularly for the intervention nephrologist, for all nephrologists in general, but particularly for the intervention nephrologist, it's very, very important to know the aspects of the ultrasonography related to the vascular access, kidneys, bladder, lungs, heart, IVC, and the other things used in the critical care nephrology or intervention nephrology. So I start with my presentation. So today is my topic is basics of the ultrasonography. So it's not working, Puneet. Yeah. So who is intervention nephrologist? So intervention nephrologist is a specialized person who cares about the vascular access or the peritoneal access and maintains and try to maintain it at every step for performing better and in the proper way. So the intervention nephrologists have undergone specialized training to perform the procedures on hemodialysis and the peritoneal dialysis accesses. Traditionally, these procedures have been delegated to a variety of specialists. For example, intervention radiologists are doing the procedures, they are doing the perm cats, they are doing the endovascular procedures in the intervention nephrology. They are performing the peritoneal access procedures. So cardiologists, they are putting the perm cats, even they are putting the they're doing the endovascular procedures for the access. Plastic surgeons, urologists, CVTS surgeons, vascular surgeons, they're all doing the work of the vascular access. So what it causes the resultant delay in the diagnosis and initiation of the therapy because they have their own work. Cardiologists is busy with the coronaries, they are busy with the peripheral arteries. Vascular surgeons busy with the diabetic foot, they are busy with the grafts, other things, the peripheral vascular disease. And intervention radiologists are busy with all their own work, ultrasounds, MRI, CT. So for them, it's the least uh, priority job for the vascular access. So that to avoid those delays in the diagnosis and the initiation of the therapy. For example, a patient is having the stenosis of this or the poor flow in the AV fistula. So to diagnose it, you have to send the patient to the radiologist for the Doppler. He will give his own diagnosis. It will be not exact what you need, and then you will initiate the therapy. You have to send him to the vascular surgeon, or you have to send to the intervention radiologist or the cardiologist. So this all actually it delays the treatment time and the diagnosis time. So to avoid those delays, nephrologists have taken the initiative, or multiple nephrologists have taken the initiative to perform these procedures themselves. So recent data have emphasized that the nephrologist can safely and successfully perform these procedures with the excellent results. So intervention nephrology is a new and the emerging subspecialty of the nephrology. It's not a actually established subspecialty, but it's emerging, it's new to everybody, new to me, new to you. So vascular, so the intervention nephrologist, he performs the physical examination of the access, mapping of the vascular access, then the pre-operative vessel evaluation by ultrasound Doppler. If he finds there's some difficulty or some so the patient is obese, or there is no obvious veins in the Doppler, so may go for the venography. So he creates the AV fistula, creates the grafts, and maintains those created grafts and fistulas, and manage their complications by treating their stenosis, by treating their thrombosis, timely diagnosis, and also put the dialysis access catheters and their managements. By inserting them, we can exchange them, we can remove them, and they can repair them. They can do the catheterograms, they can do the repositioning of the catheters. All these things are done by the intervention nephrologist. And intervention nephrologist can do the ultrasonography of the graft kidneys, can do the ultrasonography of the kidneys, KUB, all the KUB, the lungs, echo. So the goal of performing procedures by nephrologist is the effective and the timeless anticipating of the clinical problems affecting the renal patients. So it's the effective and the timeless anticipation. And the success of this goal ensures the ideal management of renal patients with effectiveness, safety, and lower cost of the public health system. So certainly nephrologists must have adequate training and develop the necessary skills in the new fields as a prerequisite for the success of the concept. So there are the multiple centers which are now started with the training of the intervention nephrologists. HGPJ has started with training for post-doctoral fellowships in intervention nephrology for 1 year. And CMC Vellore has started with the fellowship program. And overseas, you can go through the ISN, Indian Society of Nephrology, and for the training program, observership for 3 months. And you can go the countries like USA for the observerships or for the fellowships, proper fellowship for the 2 years. So now today's topic is the basics of the ultrasonography. So for nephrologist or any doctor, any physician, ultrasound, it appears that's the most difficult thing to do. But actually it's very easy to do, it's easy to perform, and it's easy to interpret. Very easy to handle, very easy to interpret. It's a handy thing. It's a bedside. You can do the bedside ultrasonography and get the diagnosis and immediate diagnosis. After that, you can go for the treatment process. So the topic outline is the ultrasonography, basic physics, terms, what are the meanings of those terms, basic components of the USG machine, the knobology, then the modes of the ultrasonography, adjustment of the equipment, how it's adjusted, what are the probes or transducers, the artifacts produced by the ultrasonography, and documentation of findings. So ultrasound is not new to us. It's from is a million of years that we know the echoes in mountain. There's an echo of the sound. When sound is produced, it's echoed by, it's echo back by the mountain surfaces. We know the submarine sonar in the submarine, when the sound is produced by the submarine, and it's reflected by the object, and we can locate the object and the position of the object. So like bats from millions of years, they are producing sounds, and it's reflected back from the object, and they can judge the distance where from it is coming, and how much is the length or the breadth of the object, and accordingly they judge the prey. Same for the sonar. So the basics of the sound, actually sound is a mechanical energy. It is a pressure wave or is a vibration heard by the human ear. So the human ear has a capacity to hear the frequency of 20 hertz to 20,000 hertz. And the sound, it travels in all mediums except vacuum. So when the frequency is about 20,000 hertz, it's known as the ultrasound. So diagnostic ultrasound uses very high frequency, that is around 2 to 30 megahertz, then the million hertz, that means the million hertz. We'll understand in the short of time. So this is how there's a less than 20, it's known as infrasound, which is heard by the elephants, giraffes, and the human here is audible frequency is 20 to 20,000 hertz, and the ultrasound is heard by the bats, the dolphins, and the other animals. So terms used in sound physics is the cycle. So the wave, this is the complete wave. This is the wave, the positive wave, and the negative wave. The positive wave, negative wave. The positive part of it and the negative part of it completes a cycle. So this is the cycle. From here to here, it's a cycle. So one cycle is the cycle. Okay, so we'll go to the frequency. Now this is the cycle, the positive wave, the negative wave is known as the cycle of the sound wave, and the frequency is number of cycles per second. How many cycles if this is the cycle from here to here or here to here, this is the cycle. How many cycles are passed through this medium per second is known as the frequency of the sound. It's like this. How many cycles pass through the per second is known as frequency of the sound. So, and now the wavelength is the distance between the similar points on two back-to-back waves, and length between the beginning and the end of the cycle, and can be measured at different points. So this is the beginning of the cycle and this is the end of the cycle. So we can measure here, from here to here is a wavelength, or we can measure here to here, we can measure here to here. So the wavelength is the distance between a cycle, two positive waves, two negative waves, or in between the cycle. So more the frequency of the wave, the less will be the wavelength. The shorter will be the wavelength. More the frequent wave, less will be the wavelength. And less frequent the wave, more will be the wavelength. So this wavelength is more here, wavelength is shorter here. So wavelength and frequency is opposite to each other or reciprocal to each other. So now the amplitude is the height or the force of the power of the wave. It is a dynamic factor in the sound wave. In the ultrasound, cycle, frequency, and wavelength, it remains the same. So this is the dynamic factor. We can change the amplitude of the wave, but we cannot change the cycle of the wave. It's fixed, frequency of the wave or the wavelength of the wave. So for the ultrasound, these three things are fixed, but we can change the amplitude of the power of the wave. We can change. So this is the power of the wave. It can be more powerful, it can be less powerful. So that means the amplitude of the wave can be changed. So how a sound wave travels? As the sound wave is a pressure wave, it travels in the medium. So it has a condensation or compressions and the rarefaction. So this is the compression or condensation, this is the rarefaction. So this is one cycle. One compression and one rarefaction is one cycle. How many rarefactions and compressions pass through 1 second is known as frequency of that wave. For example, this is 20. So that means 20 hertz means 20 cycles per second. That means 20 rarefactions and 20 compressions per second. So it's like this. You have a wave, the sound object is producing wave. It goes like this. There's a compensation or compressions or the condensations and the rarefactions. So compressions, as we already discussed, that compressions and the rarefaction per second is the hertz per second. That means cycles per second, which is frequency. So properties of ultrasound, there are few properties that the ultrasound have velocity. So ultrasound velocity depends on the density and the compressibility or the stiffness of the medium. So air has a least velocity, the sound wave in the air has a least velocity, and in the bone, when it passes through the bone, it has highest velocity. The human tissue has a velocity of the machine. It's a, in the ultrasound machine, there's a default that the wave which is produced by the ultrasound machine, it will pass at the rate of 1540 meters per second through the human tissue. It's default to the this ultrasound machine, whether it be fat, water, bone, or air. There's a default that it will pass at the 1540 meters per second. That's why the artifacts are produced in the air when you do the lung ultrasound, because there's a least velocity in the air, in the lungs, but it is produced. The machine knows that the velocity is 1540 meters per second, but the actual velocity is less. So, and in the bones, it has highest velocity, but the actual velocity is this, but the default velocity is this to the machine. So that way it produces some artifacts. So the velocity is maximum in the bone and least in the air. So it's denoted by the C, and the C is equal to, that means velocity is equal to wavelength, product of wavelength and frequency. C is constant to the USG machine, that means it is 1540 meter per second. So the frequency is inversely proportional to wavelength. More the frequency, less will be the wavelength. Less will frequency, more will be the wavelength. So there is something in the sound, we all know, we have read it, that there's a reflection of the sound waves. So return of sound wave is known as the reflection of sound. Greater the reflected wave, brighter will be the echo. When the sound wave is produced from the probe, when it hits the object, if the object is hard, so the brighter will be the echo. So it will be, there will be the bigger wave, reflected wave. So there is something known as reflection. So brighter will be the echo if the reflected wave is big. It's like this. When the ultrasound produces the wave, it hits the medium. So there was the reflected wave, this is the reflected wave, this is the passed wave. And when it reflects back, it gives on the monitor, it gives the image of this object. So refraction is the reflected wave doesn't return back to the probe. It occurs on the boundaries of the tissue at angular spaces like the liver, diaphragm. So when the ultrasound wave produces the wave, sound wave, some of it is refract. It refracts, some passes, and some reflects. This is the reflected wave, this is the refracted wave, this is the passed wave. It's like this. So this will be seen as less brighter thing, because the refracted wave never hits the probe. So the scattering is the echoes originating from the relatively small, weakly reflective, irregular shaped objects. For example, there's a blood vessel, and in the blood vessel, there's a blood. So blood is a poorly reflective object. So whatever we see the black thing in the vessels. So now this is like this. There's everything is scattered. Something is scattered there, something is there, something there. So less of the waves are reflected back to the probe, so that this appears black. There's nothing is there, like nothing is there. So the blood appears black, fluid appears black in ultrasound. So the absorption, the reflect the wave produced by the ultrasound, it may get reflected, it may get refracted, or it may get absorbed, or it may get scattered. So absorption of the waves like this, when the wave is produced, the object absorbs it. Some of the waves are absorbed by the object and the heat is produced. That's why now there are the, after invention of the 4D, 3D, this ultrasound for the fetal ultrasound particularly, now it is said that they cause the harm to the fetus by producing heat, so that there should be infrequent this examinations, ultrasound examinations, like we have a X-ray rays or other things. That's the same thing, that the ultrasound produces heat, but the amount of heat is very less to hurt the tissue. But for the fetus, it is significant. So, or the wave can attenuate. So the wave can reflect, wave can refract, wave can absorb, wave can scatter, or wave can attenuate. So attenuation is the reduction in amplitude of the ultrasound wave through the imaging medium. More the attenuation of the wave, poor quality image will be produced. Like this, there's a large organ. So when the wave is produced, it goes to the through the organ and it attenuates. It attenuates, and the reflected wave will be very less. So the penetration, when the deeper tissue, the image quality will be very poor. Here the image quality will be good. Here the image quality will be the poor, because it attenuates by bypassing the tissue. So the second property of the sound wave or the ultrasound is acoustic impedance. So what happens? The acoustic impedance is the resistance to the propagated wave through the tissue. When the wave is passed through the tissues, multiple tissues, so they have their own resistance. Liver has its own resistance, kidney has its own resistance, kidney capsule has its own resistance, diaphragm has its own resistance, gut has its own resistance. So the tissues have their own resistance. That means the impedance, they have acoustic impedance. So it depends on the velocity of the sound and the density of the tissue. So its units are megareals, and the acoustic impedance is equal to the density of the tissue and the velocity of the tissue, the velocity of the sound, the density of the tissue and the velocity of the sound. So acoustic impedance is lowest for the ear and highest for the bone. That means ear, it reflects everything, and bone, it absorbs everything. So like this, when the wave is produced, it goes to the one surface. This is the this has more acoustic impedance. So the reflected wave is bigger. When it goes to the other surface, the reflected wave is smaller. And it goes to other surface, the reflected wave is again bigger. So there's a different tissues with different acoustic impedance, and they produce the reflected waves accordingly. So that the ear and gas reflects, or the gas reflects almost all the energy of the ultrasound pulse arriving through the tissue. Acoustic shadows is seen behind the gas bubbles. So the black shadow, when there's a gas bubble, it appears that it's a white thing, and behind it's all black. That's known as acoustic shadow. When there's a bright stone, for example, or the bright the air in the lungs, or air in the gut loops, so it appears smudgy white, and with the all of behind it is because it doesn't allow anything, any sound wave to pass through it. The same reason for the using coupling agents, jelly between the skin and the transducer, so that the sound waves should pass nicely through the from the transducer or the probe to the skin or the tissue. And the another property is resolution. So that means is an image quality. So it depends on the frequency and the wavelength. This is the important concept for the ultrasound. So higher frequency have less wavelength. We know that they are reciprocal, and higher frequency have less penetration. High frequency, less penetration, high resolution. That means the linear probe, which we use for the vascular things or the superficial tissues, so they have a high frequency, and those have high resolution, but they have less wavelength. So with less wavelength, their penetration is less. Opposite for the low frequency, that if the low frequency probe, for the curvilinear probe, for the ultrasound, because we need more penetration. So less wavelength, less frequent probes, less frequency probes, for example, 2, 3, 4, 1. So we use 2 megahertz, 3 megahertz, 4 megahertz for more penetration, because they have high wavelength, they have more wavelength, more penetration. But with the penetration, the image quality resolution is less. But for the superficial tissues, there's a linear probes, they have high frequency, 5, 7, 10, 15, 20. So they have high frequency, their wavelength is less, but their resolution is very high. We can make out the smaller, even very tiny, we can see the nerve even. We can see the minute things in it. There is a high resolution, we can have axial or the lateral resolution between two structures laterally, or between two structures actually, we can make out the difference. But they are less penetrating, and their penetration is less. So we can see up to 4 centimeters only. So now there is something known as piezoelectric material or effect. Actually, the piezoelectric material, it converts mechanical pressure. When the mechanical pressure is put on the this piezoelectric material, ultrasound pressure or the sound wave, when you expose piezoelectric material to the sound wave or the pressure wave, there is an alteration of the thickness of the piezoelectric material, and it produces voltage on their surface. When the sound wave is exposed to the piezoelectric material, it changes its shape and it produces electric voltage on their surface. This is known as piezoelectric effect. Earlier, the piezoelectric material was used as quartz. Now it's lead zirconate titanate, PZT. So indirect or reciprocal piezoelectric effect is actually used in ultrasound. That means we put the electric current to the piezoelectric material and it produces the sound. So like this, so voltage is produced or is exposed to the piezoelectric material. There's alteration of thickness of the piezoelectric material, and it converts electric energy to the ultrasound. And ultrasound, when it goes to the body, it reflects back the waves. Those waves, it hits the piezoelectric material, it again changes its thickness, and it produces the energy. That energy is taken by the ultrasound machine and produce the digital image. So there's a reverse piezoelectric effect by producing from energy to ultrasound, and the piezoelectric effect from ultrasound to the energy. It's like this. We put the energy on the piezoelectric material and there's a production of the ultrasound. This is known as reverse piezoelectric effect. And this is the piezoelectric effect. Ultrasound wave, when it hits the piezoelectric material, it produces the energy. This energy goes to the ultrasound machine and it produces the image. It's the same thing. It's neutral. When it produces the change, when this is the sound waves or the ultrasound waves, it changes and produces the current. When the current is produced, it produces the ultrasound waves. It's the same thing. This is like this. It produces the waves, they reflect back, and then it gives the image. It produces the image. So now the components of the ultrasound machine. Is there any Am I clear to everybody? Mr. Puneet?
Yes, sir. The audio is clear, sir.
Okay. Any feedback?
Yes, sir. In the chat box, students have mentioned yes.
Okay. So I will continue the same. So we have a, sorry, I have a phone from the hospital. Give me a second. Sorry, there was an emergency. So now the basic components, ultrasound machine. So there's a ultrasound machine have few components. They have 5 components of the ultrasound machine. So there's an in machine, there's an inbuilt master synchronizer. Like in the computer, there's a motherboard. In ultrasound machine, it's known as master synchronizer. It synchronizes everything. The waves coming from the transducer, the waves produced by ultrasound wave, and how many waves should go to the transducer, how many electric current, how much electric current should go to the transducer, how many waves to produce by the transducer. It all depends. Its memory, it synchronizes everything, how the electric current is changed and form the digital analog. So everything is synchronized by the master synchronizer. So it's the brain of the ultrasound machine. So there's a one more component of the ultrasound machine. It's a pulsar. So beam former, it forms the current. It forms the pulse current. So then the transducer, what we all see in the, what we have taken in the hands, the transducer, which in common language known as probes, and then the receiver, and then the display, what is in the monitor, and the storage. So we can store all the image we can store. There's a storage space. So they have 5 major components of the ultrasound machine. So master synchronizer is a brain of ultrasound machine. So it organizes times function of the individual components in order to operate as a single integral system. So pulsar, it creates electric signals to stimulate the piezoelectric effect, to piezoelectric material. It's determined by the pulse repetition period. That is the time between the 2 pulses generated. For example, we have the ultrasound, we have some this setting in the machine that the more the we have to generate more pulses. So the time between 2 pulses will be less. So pulse repetition period is how much time it will take to repeat the same pulse. How much time it will take to repeat the same pulse. So pulsar has 2 properties. One, it is pulse repetition period and the pulse repetition frequency. How frequent it, number of pulses per second. So number of cycles or number of pulses per second, how frequent it should be. Is it 2 megahertz, 4 megahertz, 6 megahertz? So it depends on the pulse repetition frequency and the time between the 2 pulses. It's a pulse repetition period. These 2 are we can manipulate in the ultrasound machine. So we should know these things. So then the amplification. So what we saw, the amplification is the dynamic factor. So it's the electric signal power or output from the machine. It has a mechanical index. So the safe limit for the ultrasound to produce a minimal heat in the absorption of the sound waves, it should be 0.5 to 1.2. Its mechanical index should be 0.5 to the 1.2 to be on the safer limit. It has a bio effect. It produces the heat, so it damages the tissue. So more amplification, a more generation of the heat in the tissue. And then the transducer. It has 2 modes of working. It transmits ultrasound and it receives the reflected wave back. It's the most expensive and the fragile component of the ultrasound machine. So it's like this. This is the casing. This is the casing of the this is the probe. There's a backing layer. There's a crystal, piezoelectric material, and the matching layer. So matching layer is the layer what you see, the blue layer on the probe, and the crystals, and back of the crystal is the backing layer. This backing layer is behind the piezoelectric material because it prevents the reversal of the generated sound waves. So sound waves produced by this, some goes here, some goes here, some goes here. So it streamlines to the only one side. Backing layer is for that. So matching layer is a soft, spongy layer. It's on the surface of the transducer. It transmits the sound waves from the piezoelectric material to the skin. The receiver is of the ultrasound wave from the subject is converted to the electric signals by the transducer. So the electric signal produced by the transducer is then received by the receiver component of the ultrasound machine, and the electric signals are sent for display on the monitor. So there are 5 operations on it. There we can amplify the wave coming from the energy wave coming from the ultrasound. We can amplify it by producing the amplification. We can zoom it out. We can zoom it. We can compensate it. We can compress it. We can demyelination it or rejection it. Some waves are negative, but receiver has some properties that it cuts all the negative waves, produce the positive waves. So the image quality will be more. So some are the small, very small waves, it rejects those waves. So it has multiple operations so to give the better quality of the image. Now the display is the analog of electric signals from the receiver. So electric receiver receives the electric signal, which converts it to the digital analog and displays on the image. So there's a bit more the bytes. So 8 bits form the 1 byte, more the bytes, the pixels, the more the pixels, it is clear the image. And there is something known as gray shades in the ultrasonography. We'll see later. Then the storage, the data saved as digital memory and needs to be saved by clicking the save button. Now there's a modes. It's the most important topic in the ultrasonograph is the modes of the ultrasonography. So there are A mode, there are B mode or the brightness mode, and M or motion mode, and the color Doppler mode, CD mode. So there are 4 modes of the ultrasound, that is amplitude mode, brightness mode, which is known as B mode or 2D mode, then M mode or motion mode, and color Doppler or CD mode. So amplitude mode is the reflected waves is traced on the graph. So there's a graph paper. It's not currently used in diagnostic ultrasonography, but sometimes in the eye we can see the amplitude mode. So this is the, for example, there's an object. So when the sound waves are produced, it hits and they reflect back. When they produce the more amplitude waves, that means the surface is stronger. So that way it gives a image-like thing, that there's a soft tissue, there's a hard tissue, there's a bleed in the eye, there's a foreign body in the eye. It gives more reflected wave, will be more amplitude. So this mode is now obsolete. It's not used in the diagnostic ultrasonography. So the brightness mode or the 2D mode, which is known as B mode, is also known as 2D mode or the grayscale mode. It produces the images in the scale of gray, from black to the gray, black to white. So image made by it's made by the several dots, small dot. One reflected wave, for example, this is the kidney. So one reflected frame from the capsule, reflected wave from the capsule give the white like thing because it is tougher than the tissues, this dense tissue than the kidney parenchyma. Then the cortex, it has more of glomerulus, means more of blood. Then medulla, it's a brighter thing. So there's a tissue, there's a fat in between the medulla. So there's a medulla gives the whiter this image, black image, or the less brighter is cortex, and then the capsule, then the surrounding muscles, fascia, fat, every bit or bite several the bite from the tissue, it forms the image. So brightness of each dot is determined by the amplitude of the return echo signals. More the dense tissue, more will be the amplitude, more brighter will be the tissue. So there are 256 shades of the gray in the ultrasound, 256 shades of gray. So it gives two-dimensional information about the cross-section of the tissue. So this is the white thing, this is the black. So from white to black, there are 256 shades, which the brighter tissue, it will give this this portion, less brighter, and then least brighter will be, or the liquid or the blood will be black. So like this is the skin, this is the transducer surface, this is the skin, this is the subcutaneous fat, these are some muscles, abdominal muscles, and behind this is the capsule of the liver, this is the liver, and this is the fascia around the Gerota's fascia around the kidney. These are the capsule of the kidney. This is the cortex of the kidney, and this is the medulla. So every tissue has its own density. The sound wave produced by the ultrasound has a 1550 meter per square through speed of the, this is 1540 meter square. It passes through the this tissue, and the reflected waves gathered by the transducer produce an image which is in 2D, two-dimensional image, and it has 256 shades of gray, and as per their density of the tissue, it gives the image, it produces the image on the monitor. So these are the, there's a hollow things, and there's a blood in these hollow things. These are the vessels, this is the artery, these are the hepatic arteries. So there are some renal arteries here. This is a medulla, it appears the white. So this is how the ultrasound produces image. So this is the organ, this is the ultrasound probe, this is the wave. This, when it goes there, it produces the liver. When it goes down, it is reflected back, it produces the kidney. So this is the liver, this is the kidney. This is how it produces the liver, and this is how there's a liver. It produces the liver here on the image. When it goes down, it produces the kidney here. So this is the kidney, this is the liver. So time is equal to distance. More the distance, it will take more time to reach there, and it will be below the, on the lower side of the image. When the wave takes more time to reach the organ, it will be at the lower end of this. When it is less time to the organ, it's at the upper part of the screen. Okay. So now third mode is motion mode, or the M mode. So it reflects and plots the motion of the structure. That means motion over time. It's also known as time motion mode. It's not a picture of the structure. No, it's not a picture, but it's a diagram that shows how the position of it changed during the course of the cycle. I will just explain that. So IVC diameter in motion during the respiration, we can see by the M mode. Cardiac chambers and valves, their movements, we can see. Pleural sliding and vascular structure motion. So for example, this is the ventricle. This is the ventricle, their motion. So this is the septum. This is the wall of the heart. So this line, this is the movement of the structures at this line. Not here, not here. It's only at this line. How it moves here. This goes here, this goes here. There's a construction of the cardiac chambers. There's a construction of cardiac chambers at this line. Not here, not here. So it's at this line. So it produces something like this. So this is the valve in between. So there's a wall motion. There's a posterior wall motion. There's a septal motion. So this is the septal motion. At that particular point of image and structure, and this is the motion of the wall at that particular point of MO. So this at here, there's a motion of the posterior wall, motion of the anterior wall, and motion of the valves. So there's a motion of the valves, there's a motion of the anterior, or there's the septum, and the motion of the posterior wall. At that point, it's known as M mode, or the motion mode, or time motion mode. So the fourth mode is color Doppler mode, or the seeding mode, what we use in the vascular access. So it's used to detect the blood flow, the speed of the blood flow, or the motion of the blood flow, or the direction of the blood. Based on the charge of the reflected signals from the small moving structures, frequency of reflected signal is altered, and the ultrasound machine interprets it as a motion. So there's a change in difference. When there is a change of difference in the reflected wave and the transmitted wave, when the transmitted wave and the reflected wave, when the wave is produced by the transducer and the reflected wave produced by the structure, for example, the blood cells, when they hit the transducer, when there is a difference between the two, transmitted wave and the reflected wave, there is a production of the color. So that's known as color Doppler, like this. So transmitted wave is the frequency of the transmitted wave, Ft, and the frequency of the reflected wave, Fr. So we should remember that the blue is away, B-A-R-T. Blue is away. That is blue. When you get the color of blue, that means the reflected, that the blood is moving away from the transducer. And when you get the color red, that means the blood is moving towards the transducer. It's not an artery or vein. For example, you turn the probe upside down, you will get the red in the vein and blue in the artery. So that means when the blood is going away, or the object is going away from the transducer, its vein it gives the blue color. When the object or the reflected wave is coming towards the transducer, it gives red color. It's like this. When the transmit, this is the transmitted wave, Ft. This is the reflected wave. So when the transmitted wave is exactly equal to the reflected wave, there will be no color. There will be no color, because there is no difference in the transmitted and the reflected frequency. But when the transmitted frequency is less than the reflected frequency, that means the object is coming towards the probe. The reflected frequency is more, Fr is more than Ft, it gives red color. Okay. When the transmitted wave is more, or the reflected wave is less, Fr is less than Ft, it gives blue color. So it gives blue color. When the reflected wave is less than the transmitted wave, blue color. When the reflected wave is more than the transmitted wave, is the red color. When the reflected wave is exactly equal to the transmitted wave, it gives no color. So there is something known as power Doppler imaging. Power Doppler imaging is actually the map of the strength of the Doppler signals. They are Doppler signals. They are the reflected waves from the tissues, but there is no frequency shift. Like the transmitted wave has less or more frequency than the reflected or transmitted wave. But in the power Doppler imaging, it gives strength to the Doppler strength. It gives strength to it does not have color. It does not have red or blue color. It has it's an orange color. So it gives orange color to the tissue, the blood flow or the low flow areas. It's used in the organs like small vessels, low flow places like ureteric jets. Like this is the periphery, this is the kidney, this is the main renal artery, this is the small segmental arteries. So it gives power to the Doppler waves. So it's known as power Doppler effect. So power Doppler effect is when you want to see the segmental arteries, when there's a low perfusion places, like we have to see ureter jets. So there you can see you can use the power Doppler mode. So there is one more mode that's known as pulse wave Doppler. Pulse wave Doppler is a measures accurately the velocity of the blood flow in the precise location. For example, there's a blood vessel. How much blood is passing through this vessel when you screen it is known as it's given by the pulse wave Doppler. So it's a real time. You can see in the real time how much flow is going on, and there is something known as Doppler gate. So you can get RA values by this application: peak systolic velocity, acceleration time, deceleration time, and diastolic volume and blood flow volume in the blood vessel. Like this, for example, this is an aorta. This is the Doppler gate. This is the Doppler gate. Is the how much blood is going through this Doppler gate? How much blood is going through this Doppler gate? It is reflected here. So this is the here up to here. It's a peak systolic velocity. This is end diastolic velocity. So you can see peak systolic velocity and diastolic. This from here to the peak. This is the acceleration time. When there's a parvostatus appearance, that the wave is like this. So there is the wave takes time to reach the this peak. So this is the acceleration time. Their acceleration time is more than 70 milliseconds. So you can get the acceleration time, you can get the deceleration time, you can get the end diastolic volume time, peak systolic velocity, end diastolic velocity, and the blood flow. When there's a t mean of the velocity, when you're the mean of the velocity, you can get the blood flow passing through this vessel. How much blood flow goes through, how many mLs per minute is going through this vessel. You can get by this pulse wave Doppler. So you can get RA values, resistive index value, peak systolic velocity, acceleration time, deceleration time, and diastolic and blood flow volumes. Now, the most important thing is the probes or the transducer of the ultrasound machine. So this is the part of the machine with which it talks and listens. We have already discussed that. It generates ultrasound signals by piezoelectric material and receives back the echoes. It has many types and different frequencies. So there is something most important in intervention nephrology: high frequency probes. High frequency probes produce good resolution, as we already discussed, but the depth of penetration is limited. It's limited to around 4 centimeters. It's used to see superficial tissues only. For example, subcutaneous tissue, vessels, nerves, muscles, joints, tendons, lymph nodes, breast tissue, and in the small child, we can use the linear probe because the distance, organ distance is not that much. And the low frequency probes produce poor resolution, but they penetrate deeper. So we can see the kidneys, gut, liver, retroperitoneal organs by low frequency probes because their penetration is more. They are used to look for the deeper organs like kidneys, liver, intra-abdominal organs, deeper vessels. Now the types of probes. So we have curvilinear probes, C probe, curvilinear probe, or abdominal probe, commonly known as abdominal probe. It has low frequency. It has a 2 to 6 megahertz frequency. That is 2 to 6 million hertz, million cycles per second. 2 to 6 million seconds per cycles per second is the frequency. It has wide surface area. It's a bigger probe. It has the examination area is more. It has fan-shaped scanning area. It's like the fan-like thing. It produces the image like fan, and it is for deeper structures. So it has good visualization of structures more than 4 centimeters away from the probe. Less than 4 centimeters from the probe, it has poor visualization. So there is written something C568. It means that it has a curvilinear probe. It's 5 megahertz and its surface area is 68 millimeters is the surface area. This is the information we can get from the probe. It's written on the probe. So it's the indicator on the probe. This is the area where the piezoelectric material is put. This is the matching layer. This is the case of the probe. So it produces image like this. It's a fan-shaped image. So the image we get on the ultrasound, this is the monitor, it will be like this. Yes. So indicator on this side. So the whatever is image is like here, near the indicator on the side of indicator will be here. So linear probes or vascular probes, commonly known as, it's as a small surface area. They have small surface area. They emit waves at equal distance in a linear fashion. They have a high frequency from the 6 to 15 megahertz. They have high axial and the lateral resolution. And the visualization up to 4 centimeters is very good. Beyond 4 centimeters, there's a poor visualization. The indicator is again same thing. The surface area is less. So it's a linear thing. It produces like a linear. So at equidistance from all waves up, the piezoelectric material is put like that. It produces equidistant rays, sound waves, like a comb. So you can see here, it's not equidistant. It produces like a fan thing. So then comes the phased array probe. It's also known as sector probe and commonly known as cardiac probe. It has a low frequency, like frequency of curvilinear probe. It has a less small frequencies from 1 to 5 megahertz. It's piezoelectric materials arranged in the center of the probe. That's known why it's known as sector probe. It's particularly sector, so that it can the waves produced, it can pass through the small areas like between the ribs. So it waves like a fan out of fans out of creating a pie-like structure. It's a pie-like structure. From the point it is produced, from the point. This is not point, this is diffuse, like a fan. This is equidistance, and this is from the small area like a pie. It produces the sound waves. So now the endocavitary probes, they have longer, slender shape. They have high frequency probes like curvilinear probe, because the distance, the penetration by these waves is already done by the structure of the probe. It has a long, slender probe. So this much already gained. So it's near the structure. That's why it has high frequency. It's a curvilinear, but at high frequency. So that it has a high resolution. It's a curvilinear wide area to wave. We can see the transrectal structures, transvaginal and transoral structures. Right. So the image and the probe orientation. Typically, the scan is performed with the right hand. Okay. And the operator being on the right side of the patient. So on the right side of the patient, and the probe should be on the right side of the operator. And the machine is on the left side of the operator. So you work with the left hand and your probe should be on the right side. Right hand. So the right side of the patient is left on the monitor. So the right side of the patient is left on the monitor. So if this is the mark, you have put the probe on the patient. This is the right side of the patient, but the image produced, this image is produced on the left side of the, so it's a monitor, so it's produced on the left side of the monitor. So use pressure of the fingers to check the correct position. Hold the probe between the thumb and the index finger, which gives support to the middle finger. And just like holding a pen, you hold the probe. So this is the indicator. This is the indicator. whatever is near this is reflected here. So it's the aorta with the hepatic arteries. So you can see the mesentery, all these things. So this is near here, and this is here. Some has different indicators. Some have like this, some have like this, some have like this. So you have to check with the finger where is the indicator. So this is the orientation. So there are only two motions of the transducer. The transducer has two motions. One motion is the vertical, this one, or the longitudinal, and the transverse. Longitudinal and the transverse. This is the motion, this is the position of the transducer, and you can move it like this. There's only two motions, one and this. One the longitudinal and the transverse. So this is the longitudinal, this is the longitudinal, or the axial and the transverse. Same thing, transverse, like this. Or you can have, in cardiac, you can have paraaxial or the axial. So this is the transverse. The structures will be seen like this, and like the vessel. We can have a transverse lesion, transverse section. This is the longitudinal section or the axial section. This like this, and this is transverse. So this is the kidney. You can see the kidney. This again, the transverse. You can see half of the kidney in the, sorry, it's the axial or the longitudinal. You can see like this, the half of the kidney in the transverse section. This the aorta. You can see the aorta. This, sorry, is the inferior vena cava. You can see the veins, hepatic veins. This is the in the marker is towards the head. This means that this is in the vertical position or the axial image. This is towards the head. This is towards the anterior abdomen. This is the anterior abdomen, and this is the foot. This is the transverse image of the inferior vena cava. This is the aorta. This is the inferior vena cava. You can see this is anterior image. This is the posterior image. This is the indicator. This is the anterior. This is the posterior. This is the lateral. This is the right. This is the left. Right, left. Anterior is A towards the probe, and posterior towards the spine. This is the spine. Aorta one side, inferior vena cava one side. Same thing for the cardiac. Now the terminology. So there's a hyperechoic thing, something known as echogenicity. Something you will be seeing the reports on the ultrasonography that's an echogenic kidneys. These are the this is the echogenic, this is the anechoic cyst or anechoic hypoechoic structure, mass, hypoechoic mass, hyperechoic mass. So there is hyperechoic, hypoechoic, isoechoic, and anechoic. So this is known as echogenicity of the tissues. So this is, for example, the tissue. This is the surrounding. So as per the surrounding, this is hyperechoic. So it's the mass, for example, in the kidney or the liver, which is this is solid and it reflects more of the waves. That's why it appears brighter. So it is hyperechoic. Now this lesion, as per the surrounding, as compared to the surrounding, it is hypoechoic. Its echogenicity is less than the surrounding. So this is the hypoechoic. And this is the isoechoic. The echogenicity is same, the mass or the structure is isoechoic to the surroundings. And this is anechoic. There is no echo in it. It's only, it appears black. So there's an anechoic structure. Like we have cysts, they are anechoic. Like we have pleural effusion, which is not serosanguish, which is not turbid. So it causes or bladder with the clear urine, it causes anechoic structure. So this is anechoic This is hyperechoic. This is isoechoic to the surrounding. This is hyperechoic because all the sound waves are passed through this. That's why it's one of the artifacts. So this hyperechoic, this anechoic, this isoechoic, this is hypoechoic to the surrounding tissue. You can make out this is the anechoic or hypoechoic to the surrounding tissue. Now the knobology, the knobs used in the ultrasound. What are the knobs we use on the ultrasound? We'll go through that. When you see the ultrasound machine, it likes this, that there are multiple buttons. But actually, it's like this. You have a channel button, you have a on-off button, and you have a play button and stop button. It's like this. Don't take ultrasound like this, take it like this. And really, it's like this. So we have a play, power, pause, stop. What do we know? There are multiple machines, multiple number of machines, but they have a same thing. There are 3 or 4 buttons which are same. What you have to use? You have to put the power on. You have to take the probe. You can see the image and gain it, or you have the depth. You see the superficial or deeper means you have to freeze the image and you have to save the image. It's only that. You take it like that. So the documentation, there is it should be written, and pictorial documentation will be there, should be there. Description of the problem that led to the examination. For example, you have fistula, which has a poor blood flow, or the after cannulation there's a retrieval of clot, or after cannulation there's a prolonged bleeding, or there's a pulsatile segment of it was having thrill, now it's only systolic thrill, or it's pulsatile. So the description of the problem that led to the examination, it should be kept in the mind. That's where how you proceed with the examination. Then the regions examined, the arm, fistula, outflow, inflow, juxtaposial segment, mid body, anastomosis, central, this neck vessels, and the description of the pathological findings. The stenosis, its diameter, intimal hyperplasia, the intimal medial thickness, the diameter of the stenosis, the length of the stenosis, outflow, its description, and then you should diagnose it. There's a 4 centimeter away from the anastomosis. There's a shock segment lesion, 1 centimeter long, 1 mm in diameter, severe intimal hyperplasia with aliasing on the Doppler and with the patent outflow. And you should suggest that go for the angiography and the angioplasty of the lesion. Thanks. So next time we'll go for the knobology. It's actually the topic is very vast. So we'll go next time to the knobology. And then if you have any questions, then ask. Puneet?
Yes, sir.
Yeah.
I think so. We can ask the questions. If we have some questions, the participants can just unmute themselves and ask, or maybe put in the chat box.
Okay. I don't think any questions are there.
If there are no questions, then we can thank our faculty, Dr. Adil. I think one has come, sir.
There is something.
Yes, sir.
Rates of parenchymal change, how it is measured. Okay, so the renal parenchyma, it changes when the fibrosis occurs in the tissues. There's more, the density becomes more, the tissue becomes more denser, so that it becomes more brighter. When it becomes more brighter than the liver, so that we can say if it is equal to the liver is brighter than the kidneys, by the way. So if the echogenicity of the liver and the kidney is same, that means there is grade 1 echogenicity of the kidneys. When it becomes more than liver, it becomes, if it's more brighter and brighter, it's echogenicity 2, 3, or 4, grade 4. We can grade like that. In comparison to the liver, we can grade the kidney parenchyma echogenicity. Equal to liver, it's grade 1. More than liver, it's more echogenic, grade 1, 2, or 3. Anything else? Okay, first time. Okay, so the maturation of the fistula means then it should be the flow of more than 600. So there's a default in the machines. You can see you can calculate it on the paper also. But in the ultrasound machine, there's a one modality. You can see you put the pulse wave Doppler, and after pulse wave Doppler, you put your calculations, and it will give the volume per minute. How much blood flow is flowing through the blood vessel per minute. So it may be 600, 800, 1000. So, but you have to see it not in the cephalic vein or the basalic vein. You have to see in the brachial artery or the radial artery, particularly in the brachial artery. You put the probe on the brachial artery, see the blood flow in the brachial artery. In lung ultrasound, is linear probe kept in the intercostal space or perpendicular ribs? It should be on the perpendicular ribs that we can go through the lung ultrasound. So when you put between the two ribs like this, so you can see the shadow of one rib and shadow of second rib. So that is the ultrasound of the lung. You should have both ribs on the side, and in between them the pleura. That's known as bat wing sign. If bat wing sign is not there, your examination will not be the correct one. So it should be between the two ribs. Between the two ribs, you can see the pleura. Any more questions? Which probe is superior for lung ultrasound, phased array or linear? It depends on the patient. If a patient is obese or thin built, when you have a thin built patient or the anterior of the chest, we can use the linear probe. But because penetration is very less. But when you have obese patient or you are scanning the posterior lobes, you have to use the curvilinear probe, the abdominal probe. Phased array probe is not good for the ultrasound or lung ultrasound. So it's for anterior chest, linear probe, or for the lower lobes or the posterior lobes, you have to see through the curvilinear probe. So the function of the gain is when when you see, it's like a zoom. So you can gain the image quality. It's not you're increasing the amplitude. No, amplitude is fixed for the machine. But when you put the gain, that means you are zooming you are imparting the echogenicity to the, for example, there's a, on the side of the ultrasound, you can have a gain on the upper field, you can gain on the middle field, and you can gain on the lower field. For example, lower field is less brighter. You cannot see the image well. So you put on the lower side of the this monitor, you can have a gain of the ecogenicity. This is a gain of the ecogenicity, or you can have a overall gain of the picture, so that your picture quality will improve. Anybody else want to ask any question?
I think, sir, the session has been quite exhaustive.
Okay.
Yeah,
So
and thank you so much, sir. Thank you. Really happy and proud to see you on the other side, as you said.
Thank you, dear.
So
Thank
we
you.
again thank you from the bottom of our hearts. Thank you, sir. Thank you for sparing your time.
Thank you, dear. Thank you.
Thank you.
Bye.
Good night.
Bye.
Okay.